Buenos tardes. So, good afternoon, ladies and gentlemen. And thank you for organizing committee and the chairman and my friend, Professor Dr. Fabian. And it's a great honor for me to visit to Colombia. This is the first time to visit Colombia and really enjoy the stay in the Bogota and Pavia. And it is a very good honor to have a presentation here. My topic is DNA methylation, new risk marker for gastric cancer. This is today's menu. So I'm an endoscopist and have great interest in the translational stage research between the clinical side and the basic research. And the task of the gastrointestinal endoscopist is as follows. The most important thing is endoscopic diagnosis. We have to know how to treat early gastric cancer and esophageal cancer, the colon cancer. The second is we have to know the endoscopic treatment for early cancer. Early detection and the early treatment is very essential. And after the detection, we manage to appropriate treatment. If the tumor has the minimum risk of the lymph node metastasis, we will perform the endoscopic resection. In addition, to know the high-risk patient of the GI cancer is also important. You know, the people who has a habit of taking smoking and alcohol is a high risk of the esophageal squamous cell carcinoma. And the patient with H. pylori, Helicobacter pylori infection is also the high-risk patient of the gastric cancer. As for the colon cancer, the familial adenomatous polyposis and Lynch syndrome is a high risk. The endoscopic resection, including endoscopic mucosal resection and the endoscopic submucosal dissection, ESD, has been widely accepted in Japan as a less invasive treatment for early gastric cancer. This slide indicates the increasing numbers of the ER endoscopic resection cases in our hospital. Recently, about 400 ESD are performed for early gastric cancer every year. Endoscopic resection is a local resection, so the remnant stomach is very wide than compared to the surgical resection. Some patient has a multiple gastric cancer. This patient, can you see the region? This patient has a 5 early gastric cancer also. All of them are very flat and superficial. Unfortunately, all of these early gastric cancer were treated by ESD successfully. In 2004, the incidence of subsequent metachronous gastric cancer and the appropriate endoscopic follow-up interval after endoscopic resection have not been determined as yet. That is a big problem for us. So, at that time, I am a resident of the endoscopy division, and I would like to investigate the incidence of the metachronous gastric cancer after endoscopic resection. This slide shows the result. The metachronous gastric cancer had an overall incidence of 8.2%. The annual incidence was constant. And the cumulative 3-year incidence was 5.9%. Almost all first metachronous gastric cancer were treated curatively with additional repeated endoscopic resection. But some patient have a multiple metachronous gastric cancer, but other does not. There is a big difference. We would like to know the difference of the background such kind of patient. Of course, metaplasia of the and atrophic gastritis is one of the clinical marker of the gastric cancer risk. But I'd like to have a biological new marker for the metachronous gastric cancer. We focus on such kind of metachronous gastric cancer patient after the endoscopic resection. The metachronous gastric cancer incidence 2.5% per year. This is high incidence. So we can realize, there is a field of the cancerization of the gastric cancer. At that time, in the same times, 2004, the Dr. Ushijima, he is the chief of the division of the epigenomics, National Cancer Research Institute of my center. He was also investigating the new risk marker of the gastric cancer. He is one of the specialists of epigenetics. So, I would like to introduce the methylation shortly. So, methylation is one of the mechanisms of the genetics change. When the cytosine has a methyl, so we call it methylation. After the DNA replication, according to the function of the methyltransferase, the condition of the methylated were faithfully replicated. It was maintained after the cell division. In addition, if the DNA was unmethylated, polymerase can recruited, and transcription was started. But if the DNA was methylated, the DNA was packed, and polymerase cannot recruited, and the gene expression was silenced. This function is one of the important factor of the gene silencing of the tumor suppressor gene. So this reason is a very important genes in the gastric cancer carcinogenesis. These genes were reported to be mutated in the gastric cancer tissues. But in our analysis, this region also methylated in the cancer tissue, and the ratio is more frequent than mutation. And interestingly, this region were also methylated in the cancer tissues, but sometimes you can see the slight band, sometimes methylated in the non-cancerous tissue of the cancer patient. So, aberrant DNA methylation in non-cancerous gastric mucosa. So I would like to association between the gastric cancer risk and the methylation. So I'd like to introduce shortly our methylation study manner. This is a gastric mucosa. We take a biopsy. We extracted the DNA from the biopsy. And we set the primer for the methylated primer and the unmethylated primer and perform the real-time PCR. That is the PCR graph. And we calculated the methylation level. It indicated the ratio of the molecules of the methylated in the total of the total molecules. So it means, I calculated the methylation level in these genes, which was methylated in the gastric cancer tissues. This is the first result of the pilot study. All of the cases is healthy volunteers. Each point indicates each methylation level. This, for example, this methylation level of this patient is almost about 20%. We divide the cases according to the H. pylori infection status. H. pylori negative, H. pylori positive. You can see in both genes, the H. pylori positive group, the methylation level is much higher than that of the H. pylori negative patient. Next, we compare the methylation level in non-cancerous mucosa of the gastric cancer patient and aged matched healthy volunteers. In H. pylori negative groups, the methylation level is much higher than that of the healthy volunteers. But in H. pylori positive groups, the difference is not so big. But in only 101 genes, the methylation of non-cancerous tissues of cancer patient is higher than that of the healthy volunteers. So, in addition to the pilot study, we investigated the next study. So we know almost all gastric cancer patient has a past history of the H. pylori infection. After the eradication or after severe atrophy, H. pylori goes away, and the current H. pylori status looks like negative. In our pilot study, the methylation level in the H. pylori negative status is association with the gastric cancer risk. So I analyzed the methylation level in normal tissues in 3 groups. Healthy volunteers, the patient with single gastric cancer patient, the patient with multiple gastric cancer. This slide shows the result. As you can see, in the filamin C, that is also new marker. So there is a good association between methylation level of the normal gastric mucosa and the number of the gastric cancer. I'd like to say again, this methylation level is of the histologically normal gastric mucosa, not of cancer tissues. H. pylori infection induces the chronic inflammation. The chronic inflammation induced methylation. Methylation is one of the important mechanisms for the carcinogenesis of gastric cancer. According to the result of our study, H. pylori infection-induced methylation. Methylation levels raise and down in the lifetime. But after H. pylori goes away, methylation level goes down to certain level. This certain level will reflect the gastric cancer risk. That is our hypothesis. And next, we investigated the effect of the H. pylori eradication for the methylation level. This slide shows the effect of the eradication to the methylation level. After successful eradication, methylation level also goes down within 1 year, 12 months. But in continuous infection, the methylation was not clear, not stable. The final part, so I would like to show the gene specificity for methylation. So this slide shows this panel is 48 CPC genes. So these genes can be methylated in gastric cancer tissues. This is a patient. We analyze all of the methylation status. That is the result. In total, these genes, the number of the genes, 26, were consistently methylated in individuals with current or past history of the H. pylori infection. Whereas 7 genes were not methylated in any patient. And 40 genes were randomly or intermediarily methylated in individuals with gastric cancer, and the remaining only 1 gene was methylated in all of the cases. Methylation profile was different in each gene. This is the summary of my first presentation. Helicobacter pylori potently induced aberrant DNA methylation. The methylation level in non-cancerous gastric mucosa was associated with gastric cancer past history. It's called gastric cancer risk. And H. pylori eradication decreased methylation level. Thank you for your attention.
¿Hay alguna pregunta en el auditorio? Doctor Otero.
Profesor Nakajima, gracias por esa excelente presentación. ¿Cuál es el mecanismo por el cual H. pylori induce la metilación de esos genes? ¿Cuál es el mecanismo por el cual?
Yes, but probably not only the stomach, but also the every tissues, the chronic inflammation induce methylation. We compare the several factors such as acute inflammation, the chronic inflammation, the status of the metaplasia, the status of the atrophic gastritis. After evaluation, the chronic inflammation will correlate with the methylation status. But the precise mechanism was not clear, not yet.
Quisiera saber si es un cambio inducido de manera indirecta por la inflamación o algún factor de virulencia Helicobacter podría dentro de la célula favorecer ese proceso.
That is a good question, and mechanism, probably some cytokine, IL-6, will induced by the H. pylori infection, or some other cytokine will introduce induce the methylation level, But probably, usually, so many report the CAG-A positive or BAC-A positive H. pylori is a strong factor of the carcinogenesis of the gastric cancer. Such kind of factor does not correlate with the methylation, or probably cytokine will induce.
Muchas gracias.
Doctor Aguilar.
Yes, we have a very difficult problem eradicating H. pylori in Costa Rica, with a recurrence rate up to 60% 6 months after giving the antibiotics. What scheme do you use for eradication of H. pylori?
Fortunately, for Japanese population, the successful eradication rate for the first triple drug therapy is 80%. And for second treatment, the successful rate is 16%. In total, 96% H. pylori eradication therapy was successful. But I don't know how do you know when do you do the following gastroscopy to make sure that the H. pylori is gone? Do you want to know after the unsuccessful cases?
Once you give the treatment for H. pylori, when do you repeat the gastroscopy?
Without a successful or unsuccessful cases, so usually I recommended the patient to repeat the endoscopic examination annually. But sometimes, in unfortunate cases, the patient with a severe atrophy or the gastritis, patient can have a small undifferentiated type that is non-curative for the ESD, but almost all the cases were curative by ESD.
Thank you.
Profesor, tradicionalmente se nos ha dicho que el cáncer intestinal está fuertemente relacionado con el Helicobacter pylori, a diferencia del difuso, donde puede estar relacionado pero en una menor proporción. Sin embargo, en el modelo de Carnero, él dice que el segundo hit y el silenciamiento del gen CDH1 es por hipermetilación. ¿Podríamos creer que el Helicobacter pylori, de acuerdo a su trabajo, tiene algo que ver en esa hipermetilación?
Of course, the H. pylori, so CDH4, the CDH1?
CDH1, cáncer gástrico difuso.
Of course, usually the candidate of the ESD in your study is a differentiated type gastric cancer. Of course, undifferentiated type gastric cancer is the contraindication of the ESD basically, but after the eradication, well, probably it's somehow difficult to reduce the incidence of the undifferentiated type gastric cancer. But next session, I will show the status of the metachronous gastric cancer. It includes the signet ring carcinoma. In total, 5% of the metachronous gastric cancer is undifferentiated type.
Felicitaciones por la conferencia. Nosotros en Colombia necesitamos estudios de hipermetilación de DNA en personas sanas para identificar aquellas personas que necesitan un seguimiento más corto en endoscopia. Quiero invitarlo a que haga un estudio de esos en Colombia, con cualquier universidad aquí representada. Hay muchos jefes de departamento, Universidad Nacional, Javeriana, Universidad Militar, San José, Ciencias de la Salud, Sabana. Necesitamos estudios de epigenética en hipermetilación y usted es el líder en Japón en eso. ¿Por qué no nos ayuda?
Okay. Of course, I would like to go to Colombia to study the methylation. But this study for the patient after the ESD. So that is not for the healthy volunteers. That is the next step, because the incidence of the gastric cancer in the healthy volunteer is very, very low. probably to conduct the prospective study for healthy volunteers is very, very difficult because the incidence is very small. And in addition, we have now still the technical problem. So to analyze the methylation is not automatic. We have to do the many PCR by myself. But next, we will investigate the automatical methylation investigation. Please wait.
Muy bien, muchísimas gracias, profesor.